Good morning, everyone. I hope everyone can hear me well. Welcome to Grand Rounds. Today is our prenatal diagnosis conference.
Okay, I'm going to make sure I can share my screen. With the double outlet right ventricle, the growth ultrasound. She met with NICU, Pediatric Cardiology, Pediatric Cardiothoracic Surgery throughout her prenatal period. And then, so patient was diagnosed with a double outlet right ventricle in her baby, not the patient herself, which is a rare congenital cardiac defect in which both the pulmonary artery and the aorta connect to the right ventricle, which always occurs in conjunction with a VSD. And there are multiple types that are classified based on how much of the aorta connects to the right ventricle. And here's just kind of a picture, since it was hard to get ultrasound images, still images of what it looks like. So basically the aorta and the pulmonary vessels connect to this right ventricle, and then the VSD allows some of that oxygenated blood to flow through, so the body isn't just circulating deoxygenated blood. And now, Dr. Curley, if you have some ultrasound echo images, I will, I guess, unshare my screen and let you share yours.
Yeah, can you guys see this screen now?
Yes.
Yeah. Okay, so I thought it would be helpful for this little kiddo, since he's already been born, to just take a quick view of his actual cardiac echo, so that we can everyone can get a feel of what his heart actually looks like, and then we can look at the fetal echo. So this is an apical view of the 4-chamber heart, and it's a sweep going from starting at the most posterior aspect of the cardiac silhouette and then moving more anterior. So I'll just kind of freeze frame a couple spots. So first, you can appreciate that the child has 2 good sized ventricles. The AV valves appear to be functioning well, but you can start to appreciate that there's a VSD here. With this being, sorry, not everyone knows this will be the right side of the heart, and the left side of the heart is over here. And so then if we're scrolling a little bit more anterior, you can really appreciate this VSD now here, that between the 2 ventricles. It's actually quite a large ventricular septal defect. And in a double outlet right ventricle, it's really important to know where the VSD is. And so this is a subaortic VSD. As you can start to appreciate, as you move more and more anterior, the left ventricular outflow tract starts to develop. And but then you can appreciate that really here comes into view right now is the aortic valve, and you can appreciate that aortic valve really is over the right ventricle, making it a double outlet right ventricle, because here you can see the outflow tract for the right, and then the left, as you've gone even more anterior, being the pulmonary artery, comes into view. So I'll just scroll through it one more time so everyone can kind of appreciate. Large VSD, we have then comes the left ventricular outflow tract here, and then the pulmonary valve comes into view there. So knowing that that's what his heart actually looks like, we can pull up the fetal echo. And so from the fetal echo standpoint, initially just showing that, yeah, he has 2 good sized ventricles. And now in this view, we've got the right ventricle over here and the left ventricle over here. Otherwise, he's got good biventricular function and no major concerns there. And then here's just a very similar sweep to the one that I just showed you from the postnatal transthoracic echo. You can now, the baby's shifted a little bit, so now the right ventricle is over here and the left ventricle is over here. You can see that there's good sizes to the ventricles, but you can appreciate that this VSD that we saw postnatally, you can see prenatally here, and then you can also appreciate that while there are 2 outflow tracts, this being the left ventricular, well, what would be the left ventricular, the aortic outflow tract, and is way off over here, coming off the right. And then the pulmonary does cross, so they are appropriately related, but basically over the right ventricle instead of the left. And then just from a flow pattern standpoint, similar thing, you can appreciate that there is that flow through that VSD that allows for the systemic output to go through the body. Anyone have any questions about that?
Okay. Thank you so much. That's really helpful. And we will finish up. Can y'all see my slides now?
Yes.
Okay. So just a little bit about, if it'll let me advance. So the double outlet right ventricle occurs in approximately 1 in 10,000 live births. It's super rare. It's frequently associated with other major anomalies that lead to a high intrauterine and postnatal loss. And also associated with genetic abnormalities such as trisomy 13, 18, and 22q11 microdeletion. There are several different types, as I mentioned earlier, and the postnatal course and type of surgery that's needed is often dependent on the location of the VSD in relation to the great arteries and the presence or absence of any outflow tract obstructions. So things to just think about with these babies is if they haven't already had genetic screening, to make sure that's completed, make sure they have their consults with pediatric cardiology, NICU, pediatric CT surgery, and plan for delivery at a tertiary care center with pediatric cardiothoracic surgery available. You want to do frequent monitoring with serial growth ultrasounds and weekly BPPs. As you would do with most babies with major anomalies. And then ideally, if you can get to 39 weeks to optimize fetal growth in preparation for surgery, that's ideal. And then depending on the other associated anomalies and genetic testing, if there is a low likelihood of survival after birth or low likelihood that the defects will be able to be corrected, to discuss possible palliative care after birth versus proceeding to like NICU and surgery. And so, as Dr. Curley mentioned, this baby has been born already. He had been getting his antenatal surveillance and growth ultrasound at 37 weeks showed new elevated Dopplers and worsening growth restriction in the fifth percentile. So the patient was sent to L&D at that time for induction, and actually was our first baby of the new year. So they had a little blurb in the news about them. It was an uncomplicated vaginal delivery. Baby weighed 2450 grams, APGAR is A9. And then we already saw that echo from day of life 1 that confirmed most of the things that had been seen on fetal echo. And baby is currently in the NICU. Last time I checked, he had some issues with calcium gluconate infiltration, and I think they're kind of trying to manage all that and help baby grow more before he can proceed to surgery. So that is case number 1. We can move on to case number 2, which is our other cardiac baby. So this patient was a 28-year-old G2 P0010, initially seen at 21 and 6 weeks as a consult from Dr. Eldick over at University due to fetal pericardial effusion and arrhythmia. This patient had been recently diagnosed with type 1 diabetes 2 years ago and was on an insulin pump, and was also recently diagnosed with hypothyroidism on levothyroxine 50. Her antibodies, Sjogren antibodies, were positive. The anti-SSA was greater than 8. But these, just of note, these antibodies were not checked until baby's findings, the arrhythmia, had been noted. And she had an NIPT that was low risk. So that's really small. There was a detailed ultrasound done at University, that was done by us, showing persistent fetal bradycardia, pericardial effusion, biventricular hypertrophy, and thickened interventricular septum. She was able to get a fetal echo that same day based on those findings, and which showed average atrial rates of 145 beats, ventricular rates of 55 to 75 beats per minute, and the atrial beats were not producing concordant ventricular beats. There was also that small anterior pericardial effusion, and an increased cardiothoracic ratio at 65%, suggestive of mild cardiomyopathy. Then the repeat echo on the 21st showed similar findings. And so my image to contribute is this one from our detailed ultrasound, just showing that anterior pericardial effusion. And I will turn it over to Dr. Curley.
All right. So again, just looking at kind of this 4-chamber view, you can appreciate 2 good-sized ventricles with, at this point, pretty good biventricular function, but hopefully you can also appreciate that you can see the atrium contracting here at a pretty consistent rate, and the ventricles also contracting, but at a much slower rate. And hopefully you can appreciate that they are not paired, but we do other techniques to prove that the atrium and the ventricles are not like concordantly contracting, and that's mostly through our M mode measurements here. And so the atrial wall is on the top line, and then the ventricular contractions is down here. And so you can appreciate that this right here is an atrial rate of 146, which is the time between these two contractions, but you can appreciate that they are contracting pretty regularly, and that the ventricles don't seem to at all be associated with any of these beats. So that's concerning for complete congenital heart block versus type 2 or type where you might have a dropped beat, or also a frequent thing we see is PACs associating with a slower heart rate. But in this instance, it seems we've done it multiple times that kind of prove that the atrial rate is not associated with any sort of ventricular rate. So we've got an atrial rate in the 140s to 150s, and then this ventricular rate is pretty steady in the upper 50s. And this is something we also, looking at just kind of the overall biventricular function at this point, it remains intact and well, but you can also appreciate, yes, there is that pericardial effusion there that will be monitored closely. And again, just another kind of view that we have of that effusion and the contractions. So she's being monitored every 2 weeks from our standpoint.
Thank you. Okay. I think those were the 2 cardiac babies. So thank you very much, Dr. Curley and Peds Cards, for signing on and helping show us all those. I know you explained it way better than I could ever even think of explaining it. So we appreciate it.
That was very helpful, Dr. Curley. Thank you.
Okay, so just to finish up with this baby and talk a little bit about atrioventricular blocks. So an AV block is a delay or interruption in impulse transmission from the atria to the ventricles due to an anatomic or functional impairment in the heart's conduction system. This conduction disturbance can be transient or permanent, and conduction can be delayed, intermittent, or absent. So there's a few different types of AV block. First degree is conduction from the atrium to the ventricle is delayed with that PR greater than 200, but there's no interruption. Second degree conduction from the atrium to the ventricle is intermittent, often in a regular pattern, and can further be classified into that Mobitz type 1 and Mobitz type 2. And then third degree or complete, which is when, as this baby has conduction from the atrium to the ventricle, is completely absent. An AV block is considered congenital when it occurs spontaneously in a fetus or a young child. So congenital complete heart block, which is what we're talking about specifically here, occurs in between 1 in 15,000 to 1 in 22,000 live-born infants. There's a few causes. The most common one that we see is due to autoimmune antibodies, the anti-Ro SSA and anti-LA SSB, and that's 60 to 90% of cases. It can also be due to structural heart abnormalities due to congenital heart disease. And listed here are a few of the ones that are most commonly associated with that L loop transposition of the great arteries, endocardial cushion defects, or syndromes with simple atrial septal defects. And what usually happens is these defects displace that AV node to a point where it's not able to function correctly. Then there's also some cases of idiopathic familial congenital complete heart block that can be another cause. So autoimmune congenital complete heart block, which is the most common type that we see. So a majority of congenital complete heart block cases are autoimmune mediated, which, like I said, those moms are tested, they test positive for the anti-Ro SSA and or anti-LOT SSB antibodies. Usually what happens, I guess from what we're used to seeing it, is a mom will come in with a known diagnosis of lupus, and we automatically check for antibodies. And then if their antibodies are positive, we start close surveillance to monitor for the development of heart block to hopefully prevent it from getting to complete heart block. And so of women that test positive for the antibodies, congenital complete heart block occurs in about 2% of pregnancies. And then once one of these women has a baby with complete heart block, recurrence rate in subsequent pregnancies is approximately 15%. And so what happens is the antibodies bind to the developing AV node and surrounding tissue in the fetus and induce apoptosis and cause fibrosis of the cardiac tissue, which is what causes the heart block. And the autoantibodies also inhibit the calcium channel activation, which interrupts action potential and conduction in the AV node, further contributing to heart block. Usually these babies will initially present in utero with fetal bradycardia. And there are cases with different types of heart block and diagnoses that they don't present until the neonatal period, but ideally we will pick it up early on so we can hopefully do something about it. So women with the anti-Ro SSA and or anti-LOT SSB antibodies should undergo more frequent surveillance with fetal echo during the 18 to 24 weeks gestation time period, as this is the most likely period for heart block development. Normal sinus rhythm can progress to complete heart block within like 7 days during this period. So that's why frequent surveillance is recommended. New onset heart block is less frequent during the 26 to 30 weeks gestation and rarely develops after the 30 weeks. So if you can get through that 18 to 24 weeks with that frequent surveillance and nothing develops, you usually can breathe a little bit easier after that time. So first or second degree heart block, ideally what happens ideally they don't develop any heart block at all. But if you are having more frequent surveillance and first or second degree heart block is diagnosed, you can do glucocorticoids, either betamethasone or dexamethasone, to try to prevent progression to complete heart block. Unfortunately, congenital complete heart block, once it gets to complete and diagnosed in utero, it's irreversible. There's nothing at this point that's been proven to help at all or reverse it. I know I saw some studies about people talking about giving steroids even for complete heart block, but it wasn't proven to help at all. So normally with these types of patients, we do expectant management with frequent fetal echo to look for development of extranodal disease or fetal hydrops. The goal for delivery is 39 weeks, but if hydrops develops or fetal distress or there's other pregnancy issues, early delivery is often indicated with emergency pacing. So what's recommended is delivery at a hospital, like a tertiary center with a NICU, and pediatric cardiology with pacemaker capabilities at bedside, because a lot of times these babies will need pacemakers immediately after birth. So this baby is still in utero. She's getting fetal echoes every 2 weeks with peds cards here, and is continuing to follow with Dr. Eldick over at university. And obviously, like I said, our goal is delivery at 39 weeks if possible, but if we can at least get to 32 to 34 weeks to help get further on and negate some of those issues that come along with prenatal delivery, that would be ideal. Okay. Next, we have our last baby, case number 3. This is a 31-year-old G1 P0, initially seen at 31 and 5 weeks by, as a consult from Albany, Georgia, due to fetal congenital diaphragmatic hernia. This patient also had gestational diabetes A1 and had an NIPT that was low risk. So initial MFM consult and ultrasound was in October, and ultrasound showed a left-sided congenital diaphragmatic hernia with intestines and stomach noted within the left hemithorax, and the heart was shifted to the right hemithorax due to mass effect from the herniated bowel and stomach. At her MFM consult, we discussed the risk of pulmonary hypoplasia and pulmonary hypertension associated with severe cases of diaphragmatic hernia, but that this would not be able to be fully assessed until after delivery. A fetal echo is recommended given the cardiac juxtaposition from the mass effect from the bowel and stomach, and the plan was for delivery at 39 weeks at AU given need for immediate pediatric surgery intervention. And discussed with her that CDH is not a contraindication to vaginal delivery. She then had a fetal echo in November that showed a rightward displaced heart, but otherwise structurally normal, just mild compression of that left atrium and ventricle. So here are some of the images from our ultrasound here, and you can see that the heart is over here on the right side, and the stomach is right up here next to it on the left side, which is not where it should be. And same thing here, just another view of the same thing as that heart over on the right side and the stomach up here. So stomach has come up through the diaphragm and is pushing the heart over towards the right. So just some learning about congenital diaphragmatic hernias. It is a developmental defect of the fetal diaphragm that allows the abdominal organs to herniate into the chest, interfering with normal lung development. It's caused when there's failure of normal closure of the pleuroperitoneal folds, which allows for herniation of the viscera into the thoracic cavity, which has several adverse effects on lung development, including reduction in bronchiolar branching, truncation and over-muscularization of the pulmonary artery tree, loss of pulmonary mass, which can cause postnatal pulmonary hypoplasia, and surfactant system dysfunction, which there's an extra letter there. Severity of adverse effects depends on the gestational age at which the visceral herniation occurs. And CDH is sporadic in most cases and rarely associated with genetic conditions. It occurs in approximately 1 to 4 cases per 10,000 live births, and the recurrence risk of isolated congenital diaphragmatic hernia is 1 to 2%. There's a few types based on where the defect is. The Bochdalic, I'm not sure how to pronounce that, I'm sorry. Hernia is posterolateral diaphragmatic defect, which is the majority of cases, 95%. The Morgagni hernia is an anterior retrosternal or anterior peristernal diaphragmatic defect. And then central hernia is very rare. It's just like it sounds, central in the middle. Herniation is on the left in 80 to 85% of cases, on the right in 10 to 15%, and bilateral in less than 2%. 60% are diagnosed on routine anatomic survey at 18 to 22 weeks. Smaller defects may be diagnosed later due to lack of herniated abdominal contents, and so the defect is not as obvious. These are not from us. I pulled some images from, these are from Up to Date just to show both sides, the left-sided and the right-sided. So left-sided is usually easier to pick up because you have this heterogeneous lesion, which is a small bowel in the left chest causing that right mediastinal shift. And so you can see the heart over here and the bowel and stomach over on the left side. And then the right-sided sometimes can be missed because the liver can have a similar echogenicity to the fetal lung, and so it can even just be mistaken as like a mass in the chest and not known that it's the liver. So here's an example of right-sided with the heart over where it's supposed to be on the left side, but here's the liver and gallbladder up in the chest next to the heart, which is not where it's supposed to be. When there is a mediastinal shift, especially like in this one with that heart over on the right side, there can be esophageal compression due to this, which can cause polyhydramnios. So that's often seen with these babies. Congenital diaphragmatic hernia can be isolated or associated with additional abnormalities. Sorry, is there someone need to mute themselves? Okay. So it can be isolated or associated with additional abnormalities, major structural malformations, chromosomal abnormalities, and or single gene disorders. Prognosis for survival is less likely in the setting of abnormal microarray or findings suggestive of a fetal syndrome, serious associated anomalies, large volume of liver herniation, or lower fetal lung volumes. And just of note, absence of liver herniation is the most reliable prenatal predictor of postnatal survival. Some fetuses may be appropriate for fetal surgery with in utero tracheal occlusion. This is an investigational procedure to prevent or reverse pulmonary hypoplasia and restore adequate lung growth. And it doesn't have the best outcomes as of now from what I was able to find, but just something that was noted during my research. Usually these babies, we will do normal antenatal surveillance with serial growth ultrasounds and weekly BPPs, and recommend delivery at a tertiary care center with ECMO capabilities due to the risk of pulmonary hypoplasia and pulmonary hypertension. A lot of times these babies need to be on ECMO after delivery. And so this baby has already been delivered. They had antenatal surveillance, as we said, and then the patient was diagnosed with gestational hypertension at 37 and 5 weeks gestation and had a 6 out of 10 BPP, and so was sent to L&D for induction. She ended up having a primary cesarean section at 38 weeks for arrest of dilation and non-reassuring fetal heart tones. This baby was still in the NICU last time I checked. They've attempted to do, or they have now done a repair. It was delayed several times due to several complications in her hospital course. She had pulmonary hypertension and was on VV ECMO for 7 days, multiple drips. And then she also had a lot of anasarca, AKI, and was on continuous hemodialysis for some time. She's had chronic pleural effusions requiring drainage, and was actually diagnosed with abdominal compartment syndrome secondary to ascites and had to have a drain placed. And then also had a pneumothorax and required a chest tube placement. But she did finally get her repair on the 26th. So sometimes it happens sooner than that, and it sounds like hers was scheduled to be sooner, but at least she's gotten it done at this time. Does anybody have any questions?
Lauren, that was an excellent presentation. And there are a couple of points to be aware of with the last case. Number one, you really can't measure lung volume accurately in utero. So oftentimes ratios of areas to other constants like head circumference are used, and those are of questionable value. The second thing is that growth ultrasounds, when you have a congenital diaphragmatic hernia, tend to be misleading because the abdominal circumference is typically going to measure smaller. So you're going to make a sort of a specious diagnosis of intrauterine growth restriction on that basis alone. So that's so you're sort of limited in following that particular aspect of it. On the case of the bradycardia, congenital heart block, there have been some case reports of doing in utero transvenous pacing. Very limited reports, but that is sometimes an option in an institution that has intrauterine fetal surgery.
Thank you. That's good to know. Any other questions? Okay.
Very nice job, Dr. Griswold. I just want to make a comment on the congenital diaphragmatic hernia baby. So as you mentioned, the overwhelming majority of diaphragmatic hernias are left-sided, as was the case with this particular patient. Generally, left-sided CDH babies do better than right-sided CDH babies, and that is because what tends to escape through that defect on the left side will be the stomach and bowel, which is generally softer and compressible, versus the right-sided solid organ, which is a liver. It is impossible to predict, as Dr. DeVoe just mentioned, what the true lung function will be in these babies postnatally. So we have to really contend with pulmonary hypoplasia, which is one of the things that will happen when the intra-abdominal contents come up onto that left side of the thorax. So you end up getting compression of the lung on the left side. If there's enough herniation of those intra-abdominal contents, then you end up having mediastinal shift, cardiac shift to the right side, and then contralateral compression of the lung on the right. So even though it's a left-sided congenital diaphragmatic hernia, that bowel comes up into the left hemithorax, compresses the left lung, shifts the heart over to the right, compressing the right lung. So we know that pulmonary hypoplasia is kind of a given a lot of times with these patients. But what really ends up being the biggest issue to manage, as we can see with this kiddo, is the fact that that sort of constant pressure in the chest leads to significant vascular changes and changes with the actual sort of anatomy of the lungs. And these babies end up developing pulmonary hypertension. And that's where they run into a significant amount of trouble. We saw that this baby was on ECMO for 7 days because of that. So that's a very difficult thing to predict, and that is why babies, even that have left-sided CDHs with just stomach in the thorax, for example, might end up on ECMO and might end up very, very sick. So that really is part of our counseling when we see these patients antenatally, just letting them know that the baby may or may not develop these complications that would really affect their long-term prognosis. Thankfully, this baby has, I think from the last time I logged into her chart in the NICU, pulled through some of these more complicated, things that were happening. But these can be pretty tough cases. And I think the mom, was pretty optimistic about, the outcomes for this baby. And I think, the postnatal challenges were definitely something she struggled with. But thank you, that was excellent.
Okay.
All right, any other comments, questions for Dr. Griswold, Dr. Montero, or any of our neonatology or peds cardiology colleagues? If not, thank you all. Have a good day.